Health experts across the country are urging Americans to take whichever brand of coronavirus vaccine is first available to them, regardless of its efficacy rate. In Detroit, the city's mayor turned down more than 6,000 doses of the newly authorized Johnson & Johnson vaccine, which was found to have a 72% overall efficacy rate in the U.S. He instead favored an allotment of Pfizer and Moderna shots, calling them the best. Well, in response, Michigan's chief medical executive said choosing one vaccine over another could be a matter of life or death and cautioned against comparing the three vaccines. So let's bring in Bruce Y. Lee, who recently wrote an op-ed on this topic for the New York Times. He is a public health researcher and a professor at the City University of New York's Graduate School of Public Health and Health Policy. Thank you so much for joining us. It's a shame that we sort of have to underline this point that if it's time for you to get that vaccine, just get whatever they're giving you. Don't turn it down. But still, people are really kind of zoned in on these numbers, 95%, 92%. And part of it has to do with maybe the media coverage that every time a new vaccine came out, that was, probably the second line out of our mouth, what the efficacy rate was. But should people be concerned about the effectiveness of one vaccine over another?
Yeah, we have to keep in mind that one single number doesn't capture all the effects and the benefits of a vaccine. Vaccine effectiveness, the numbers that have been reported, have simply been the numbers that were observed, the difference in who happened to get COVID-19 with symptoms and who didn't. And we also have to keep in mind that these trials were done at different periods of time. So the Pfizer and the Moderna trials started earlier during the summer, when transmission wasn't as high, and the J&J vaccine trials started in late September. So there's that difference. And also there's many different benefits of a vaccine. It can prevent hospitalization, it can prevent death, it can potentially prevent being infected in the first place. So there's many different types of effectiveness. So to hang your hat on one specific effectiveness is probably not a good idea. Plus, we're talking about 72%, 95%. Those are all very good effectiveness numbers.
Right, and Mr. Lee, I mean, if you get, let's say you get the Johnson & Johnson vaccine and you get it right now, once the other vaccines are more widely available, is there anything preventing you from getting another one?
Yeah, there isn't, and we have to keep in mind that most likely these vaccines are not going to last forever. The protection won't last forever. So there's a high likelihood that you'll have to get revaccinated at some point, depending on how long the duration of protection is. And also with the variants emerging, there's a high likelihood that you'll have to get another vaccination. So you can always get a different vaccine the next time around. So
because that's sort of my question about the effectiveness and the way, and Emery, I think, rightly points out that sometimes often in the media, the headlines and the way that we sometimes describe information that is coming out regarding the effectiveness of these vaccines can seem sensational to some people, and then gives people the sense, sometimes the false sense, that one is, quote, better than the other. But in your op-ed, you say that the real difference between each of these vaccines' effectiveness in preventing sickness may actually be smaller than reported. Explain that.
Yeah, because if you look at the times that the trials were actually done, the Pfizer and the Moderna trials were started earlier during the summer when transmission of the virus wasn't as high. In other words, it wasn't as widespread. And we have to keep in mind the effectiveness of the vaccine is highly dependent on your overall risk of actually getting the virus. So, for instance, the analogy is, what's the effectiveness of a T-shirt or shorts? Well, it's more effective in Hawaii versus Iceland, for instance, in a colder climate. Similarly, a vaccine will be more effective if the virus is less widespread around you. So it might be less widespread during the summer and the fall, while the other two, the mRNA vaccine trials were going on. And with the J&J trial, that was during the winter in big part when the transmission was higher. So the actual effectiveness could be smaller, the difference between the two.
And you pointed out earlier that effectiveness, means different things. It's effective at, stopping you from getting severe side effects, or keeping you out of the hospital, keeping you from dying. That's all different ways of defining effectiveness. And I would submit also, the right vaccine, the best vaccine, is the one that you can get. And that's why I think the mayor's comments, it's so short-sighted, because we know that for many, many people, a 2-dose vaccine is going to be really, really challenging. And so they may never get the 2-dose vaccine, or they might just get 1 dose and they don't make it back for the 2nd dose. So a single dose is the best vaccine for that person in particular. But I want to point out something else. You and your colleagues reported in the American Journal of Prevention Medicine that, listen, that it's better for people to get a vaccine with lower efficacy rates earlier on than waiting longer for a quote-unquote better vaccine when it comes to preventing the spread of the virus. And ultimately what we're working towards is some sort of herd immunity, right? So that's valuable.
Absolutely. So we have to remember that the vaccine is not just to protect you as an individual. It can be very effective in that. As you pointed out, Anne-Marie, it can be effective in reducing your risk of severe COVID and being hospitalized and potentially death. So that's very helpful. But the other big effect is really trying to reduce the spread of the virus in general. And that's really heavily dependent on what percentage of the population can be vaccinated and be covered. We really, once we start seeing high enough numbers, when we get closer and closer to a majority of the population being vaccinated, that's when you see real effects in terms of the virus spread going down. So if you have too low a percentage of the population getting vaccinated, the virus still can find unvaccinated people and other susceptible people to infect, and will continue to spread. So we really need to do that as soon as possible. Otherwise, the virus can continue to get a foothold or a spike hold, and that might continue into the fall and winter when the weather becomes colder and the air becomes drier, when spread might increase again. So we really want to try to get people as vaccinated as quickly as possible.
So, I mean, Bruce, one of the things I think, to be fair to just the general public, it's sort of human nature, right? I think you hear, well, this one is a little bit better than this one. I want the best one. I think that it's, even for me as a journalist, when I think about it, when I think about the moment that I will be eligible to receive the vaccine, in my head, I say, well, I hope it's the one that is, 95% effective as opposed to the one that's 75% effective, even though I know that I will take whichever one is the one that I'm given. But in your brain tells you things and does things to you. So what would you say to people to put their minds at ease?
Well, we have to keep in mind that these numbers that are being reported are overall population numbers. So the vaccine versus the placebo were given to 30, 40,000 people, different people in the trial. And all it's doing is counting the number of people who ended up developing COVID-19 with symptoms between the two groups. And when you hear that number, it's not as if you get the vaccine, there's going to be a glove around you that's 95% protective, and that there's a 5% chance that you might get infected. No, these are overall population numbers from the trials. Now, you yourself, the amount of protection could vary, and so you don't know for sure what that might be. And that's why these numbers are not like numbers for each individual person, they're for the overall population. So it could very well be that, you get the vaccine and maybe you respond better to the vaccine, or maybe you respond a little worse. So these effective numbers can really vary quite significantly. So I wouldn't really hang my hat on them at all. As long as they're above a certain number, that's really what the FDA was looking for. And, so far they've performed very well, all three vaccines.
Bruce, let me just, before Anne-Marie jumps in on this last question, I want you to hit that point once more, because I've seen a lot of Twitter doctors, in other words, people who are not doctors, who are not immunologists or, infectious disease experts, making that point. Well, if it's 95% effective, that means there's a 5% chance you might get effective. 5% in the population of this country is X. Explain that again, that's not what that means.
Yeah, it's just looking at, you're comparing the people who got the vaccine versus the people who got the placebo instead, and just seeing what is the difference in terms of the numbers. So there are fewer people who developed COVID-19 with symptoms when they got the vaccine versus the placebo. That's really measuring that difference. So there's a 95% difference in terms of the number of people who actually got COVID-19. It doesn't look at each individual person and say, what is your probability of being infected if you get vaccinated? So it's really a key difference right there.
Bruce, before we let you go, I just want to ask you about delays in distribution. And throughout this whole process, I mean, since probably December, we have been hearing sort of story after story of, the promise of X number of vaccines will be ready to go. And then, a few weeks later, we find out that's not necessarily the case. Or maybe they're ready to go, but they can't get out there because of weather, or because there's no place for them to land, or because there aren't enough people to actually give individuals the shot. So it's been a bumpy ride to get here. Most recently, Johnson & Johnson experienced a bit of a hiccup. Vaccine shipments were millions of doses less than what was expected earlier this month under its government contract. What's your take on the bumps that we've been hitting, and what needs to happen so we can kind of move smoothly towards a more widespread distribution in the coming months?
Yeah, so one of the challenges with the COVID-19 vaccine rollout, which started in 2020, is there wasn't really as much advanced planning. This is a very complex operation. So you didn't hear that much about, how are these vaccines going to actually be distributed and administered before they got their emergency use authorization. So if you think about, the trials really started in late July, and the first EUAs were issued in December. That's about 5 or 6 months to really prepare in 2020, but we didn't hear much except for, get ready for the vaccines. And so now we're really suffering the results of that lack of preparation, that lack of planning. So what really needs to be done is to catch up and install a more organized system to make sure that the production levels are high enough, to make sure that all the storage facilities are meeting the needs and not being clogged up and there aren't any bottlenecks. And then we have to make sure that the supply actually meets the demand. So what you need to do is you have to start off by saying, who needs the vaccine and how can we actually reach the people rather than establishing the supply locations and expect people to go to these places. So we really need to see, to meet the demand, how many new vaccination locations do we need to open and how can we facilitate it throughout the country. And this needs to be organized at a national level because we have to keep in mind that both the virus and people don't necessarily stay within state boundaries. So say you're in New York City, you may live in New Jersey or live in Connecticut and travel to New York City for work. So where do you get vaccinated? Do you get vaccinated in New York City or you get vaccinated in Connecticut or New Jersey? And also, what happens if one place gets more vaccines and then they can deal with, and other places don't? So you have to be able to shift across state lines. So we saw a situation, for instance, in Gila, Arizona, where they got an excess number of vaccines compared to what the demand was. So you want to be able to shift those things around. So this really needs to be organized at a national level.
All right, yeah. Bruce Y. Lee, thank you very, very much. Really important information. We appreciate it.
Thank you. Thanks for having me.